and you can now interpret them much more confidently. Okay, so let's quickly revise this pathophysiology in one slide. This is the subject of many people's PhDs, but the placenta produces, during pregnancy, lots and lots of hormones, chemicals, proteins, whatever you want to call them. One of the proteins that the placenta produces in all pregnancies is this soluble FLT, which has got a very long name. It's basically an anti-VEGF receptor, and it's secreted in large amounts during any normal pregnancy. The placenta also produces another protein or hormone called placental growth factor. Placental growth factor is a good protein. It protects the lining of your blood vessels. It also does lots of other good things in the placenta. When the placenta is stressed, what happens is you get loads and loads of this soluble FLT secreted, and you can do this in a Petri dish. If you just stress a bit of placenta in a dish, it just chucks out all of this soluble FLT, which is this anti-angiogenic bad guy protein that causes blood vessels to basically fall apart. So when you've got very high levels of soluble FLT, your blood vessels become really disrupted, and the blood vessels in your body are also blood pressure, obviously, but they're also what controls what fluid stays in your blood vessels and what fluid leaks out into your third space. By your third space, I mean your wee, your chest, your head. So when you've got very high levels of soluble FLT, your blood vessels literally get gaps in them, and you get disruption to your vascular endothelium, you get vasoconstriction, and you get very leaky blood vessels. And so when you're developing that stress placenta, that's what's happening, and what we're seeing are the manifestations of that stress response in the placenta. So that's what causes all of these clinical symptoms that we know and recognise as being preeclampsia. Now, when that disease process starts to get more established and more prolonged, what you then get is this interaction between the endothelium, which is lining all the blood vessels, and all of the other cells and proteins that are circulating in the maternal circulation. So you start to get platelets getting pulled towards the damaged endothelium and causing little aggregates, and so you get this consumptive coagulopathy picture, which eventually causes you to develop DIC if it's left unchecked, and you get very low fibrinogen. So that's why you get low platelets, and you also get other end organ congestion. Yeah, so you get pulmonary edema if the disease goes that way. You can get cerebral edema, we've talked about, and you can get liver congestion, which causes that disruption in your liver function tests. So all of those features that we sort of measure and monitor are all downstream to the fact that the vascular endothelium has become disrupted. The vascular endothelium has become disrupted because the placenta is not working. That's the long and short of it. And unless you've got parvovirus or a diabetic ketoacidosis, which is very rare, the most likely cause of that is you've got a placental problem, which is causing preeclampsia. That's kind of resonating with everyone. We now also know that preeclampsia, not surprisingly, because it's a blood pressure condition, also affects the heart, and Laura's going to talk a bit more about that later on. We've talked a bit about proteinuria already. When you're trying to use proteinuria, if you're using PLGF to diagnose preeclampsia, you can be less het up about getting your proteinuria diagnosis right. It used to be absolutely crucial because it was the thing that we really clung to for the diagnosis of preeclampsia. It's less of an issue, and if, to be honest, if I could get rid of proteinuria assessment for preeclampsia, I probably would do. They're useful for chronic kidney disease though, so it's tricky. But basically think about urinary tract infections, think about if you've got borderline PCR, think about repeating it, but use your diagnostic markers if the woman's at risk of preeclampsia, because proteinuria is imprecise and tricky. Okay, we've talked about why we should use PLGF testing. This isn't a test that's just kind of been introduced on a whim. This is a test that's been developed over the last 15, 20 years. It's probably one of the tests in obstetrics which has got the most implementation evidence, really. So there's really no excuse. It's in all of our national guidance to be not using it. So if your hospital isn't using it, again, you need to be knocking on some people's doors and finding out why. So a little bit of the potted history of the development of PLGF testing. Back in the early 2011, 2012, we did some studies where we took women and we took blood samples from them. We measured placental growth factor and soluble flit, and we looked at the diagnosis of pre-eclampsia and the likelihood of developing complications. So we did that blinded to, clinicians didn't have that information. They were our observational diagnostic studies. We demonstrated that we had a really useful diagnostic test. So we did some implementation studies, PARROT and PARROT2, which have looked at the implementation of biomarkers where you give the clinician the answer and you look at whether the test makes a difference to how clinicians behave and, most importantly, the outcomes for the women, and demonstrated that outcomes were much better when you introduce and you give the clinicians that extra diagnostic information in terms of identifying the women who are at highest risk of developing poor outcomes. And now that test is widely available and uptake is over 90% across England. Marcus and the team at APEC are doing a fabulous job trying to level that up in Scotland and in Wales, who are somewhat lagging behind. So the PARROT study, which was a large study in the UK, about 1,000 women, demonstrated really conclusively that maternal outcomes were much better in those women where we'd revealed a PLGF test to a clinician, demonstrating that you can really improve outcomes by making a diagnosis earlier, which is not rocket science, is it? You make the right diagnosis, you get the right women into a high surveillance pathway, and the women who haven't got preeclampsia but have got hypertension and low platelets with a different pathology, you get those into a different pathway, and that's really important. You don't ignore them, but you're not going to be delivering them preterm like the women you are who've got preeclampsia. It's in the NICE guidance, both the diagnostic assessment guidance and the NICE hypertension and pregnancy guidance. So, as I say, there's really little justification for not using the test. Oops, sorry, go backwards. For those of you who are using it, I'm sure you've got a flowchart that looks similar to this in terms of using the test, who to do it on, and what to do. And I know Nat's already talked a bit about women with different PLGF results and how we would manage those women. And again, this is information, and this is information that women really, really value, and there's something about being able to talk to a woman with a number and a kind of definitive diagnosis, be it positive or negative, and give her information about what's likely to happen, what we need to monitor, what we're worried about, and why monitoring her is so important. I think I've kind of made this point, but making the diagnosis correctly really does matter, because it really makes a difference to that woman's clinical care and what is at risk of developing. Okay, I think we might already be at 45 minutes. Everyone's looking a bit flagging, but we've just got a couple more topics to talk about: timing of delivery. And then we might leave severe management, and I can let you ask me any questions. Is everyone all right for another 10 minutes? Yes, okay, right, okay. I really think that, again, information is power. When you make a diagnosis of preeclampsia, women will often be like, well, what does that mean? And you're like, oh God, she's got preeclampsia. Okay, and again, having some information is really, really important. So most women who've got a diagnosis of preeclampsia, because you've made the diagnosis, you're brilliant, responsible clinicians, they're going to be fine. About 97% of them are going to get through that experience. Really important as a headline to tell women. But there are a small number, like so many things in maternity care, there are a small number of women who are going to develop severe problems. And so that's the conversation, and that's the way round I would start the conversation. So we know you've got this problem now, we're going to monitor it. Clearly, the conversation is quite different if they're 36 weeks versus 26 weeks, isn't it? But we've got this problem now. We know what the problem is. We're going to monitor it, and we're going to keep you and your baby as safe as we possibly can. 1 to 3% of women who've got a diagnosis of preeclampsia at any gestation will develop a severe complication. And for the majority of us in the UK, the complication that really bothers us is an abruption. And it's really, really important that when you've made a diagnosis of preeclampsia in any woman, that you have a conversation with her about the small risk of an abruption. Because it's no good to see her on the AAU, measure her blood pressure, check she's taking her antihypertensives, check that her platelet count's fine, her LFTs are fine, creatinine's fine, she's not got any symptoms. She goes home and has an abruption the next day if no one's talked to her about that. So it doesn't mean you necessarily need to keep all of these women in hospital, but you need to be discussing that and offering that as an option, and talking about the risk of an abruption. Again, because it happens with low frequency, most of us will manage lots and come through lots of women who've got pre-eclampsia through our services, and we won't see anyone who's had an abruption. So you can forget, you start to forget that it's a problem. Or really, was Jenny really banging on about that? Really? But seriously, you will, if you look after enough women with pre-eclampsia. We've had 15 in the last 3 years, I think, abruptions, and that's in a service where we're, monitoring, very closely these women, and it's devastating when it happens. So low risk, but it's the thing that can really get you. The other things that can get you are obviously eclampsia and severe hypertension. Severe hypertension you can do something about because you're going to monitor their blood pressure, treat their blood pressure. So that's kind of a little bit less of an issue now. Eclampsia is still a risk, about 1 in 1,000 risk of a woman with a diagnosis of preeclampsia having an eclamptic seizure. But the thing that's probably going to get you, and unfortunately is going to get the baby, is an abruption. So please, please, please remember that and have that conversation with the women, and be thinking about that complication. In terms of our other principles of managing it, we're looking for end organ disease, and when we find end organ disease, we're going to act on it and deliver the baby. So that's why you're doing your blood tests and you're asking her about symptoms all the time. And then a big part of what we need to do then is think about planning birth, which we all get tied up in knots about, because it can be a very difficult decision. So timing and planning of birth, people often say to me, when do you deliver your women with chronic hypertension? As if there's a 38 weeks, 2 days and 14 hours. There isn't a time or a gestation which you deliver with chronic hypertension. They are a group of individuals and they've all got their own individual risks and they all need their individual risk assessment. So I tend to deliver them before term, generally speaking, but some women who have got very complicated, very stable hypertension, if they are keen to get to 40 weeks and they've got a well-grown baby and they're compliant and I'm monitoring them, I would have a conversation about the fact that there's a low risk of going to 40 weeks, but if they want to go to 40 weeks, just like you would a woman with diabetes or any other medical condition. So it's about risk assessing in terms of what are the risks in front of you? Have you excluded preeclampsia? Have they got a well-grown baby? Have they got stable hypertension? And thinking about when you offer timing birth. Any time after 37 weeks is probably reasonable. For women with uncomplicated hypertension, I would usually try and get them a bit into 38 weeks if I can. And many women will go to 39 when they're keen to do so. I'm not going to dwell on that, we can share. In terms of gestational hypertension, we know that there is an advantage to the woman of being delivered once you get to 37 weeks. So if you've genuinely got gestational hypertension, make sure you're being careful about that diagnosis. New hypertension in pregnancy, once you're over 37 weeks, the balance is in favour of offering and discussing birth. That's not to say that every woman's going to accept it. It's not to say that every woman wants to be have a delivery at 37 weeks, but you should be offering it and discussing it. And most women who've got gestational hypertension will accept the offer of induction at that stage. And I know I'm whipping through these slides so fast you can't read them, but the general take-home message is that outcomes for women are better after 37 weeks with the offer of the induction. And things like intrapartum complications, caesarean section rates, increased postpartum hemorrhage, none of that's really come to fruition in this group of women because the risk of developing preeclampsia increases your risk of those intrapartum complications so much that you're better off being delivered well than you are being delivered once you've got preeclampsia. So that's the rationale, and that's what I say to the women who are understandably quite nervous often, aren't they, about that intervention. Preeclampsia, reasonably straightforward at the two ends of the spectrum. If you're less than 36 weeks, monitor very carefully. You're looking for fetal well-being, maternal well-being. You're looking for evidence of end organ disease. you're looking as to whether you can keep blood pressure safe and well controlled. And if you can do all of those things, you keep her pregnant for as long as you possibly can. And you should be documenting the circumstances by which that woman needs a premature birth. So it's really important when you see the woman at 29 weeks on the day unit or wherever she's seen, that there is an ongoing plan for how often she's been seen and by whom, and also that there are parameters which are clear, which would indicate when she should come into hospital, and when we should be thinking about considering steroids or thinking about prepping for birth. And so it's really useful to make sure that's actually written down in black and white, so to speak. 34 to 37 weeks, we can now use the evidence from the Phoenix trial, which is really, really helpful. Many of you will have recruited women to the Phoenix trial, which looked at the benefits of expectant management versus conservative management. Really important thing there was that in women who've got a diagnosis of preeclampsia after 34 weeks, 50% of the women in the expectant arm developed a complication that needed an earlier delivery anyway. So women don't get to choose, oh, I want to stay pregnant to 37 weeks. You can want to try to stay pregnant to 37 weeks, which has got a 50% chance of developing a complication, which is mean that we're going to really strongly recommend she has delivery before 37 weeks. And again, really important, we have a little stock set of phrases that we give to our clinicians to try and help them counsel women who've got intermediate gestation preeclampsia, to talk about the pros and cons of birth. We should all have the facts and figures from the Phoenix trial at your fingertips for counselling women with a diagnosis of preeclampsia between 34 and 37 weeks, and be confident again in that RCT evidence about the risks that that woman faces, and be confident about offering intervention if the woman wants to take it. We've got good RCT evidence that kind of cuts through any, oh, I keep all of my women pregnant to 37 weeks under any circumstances kind of scenario. We need to be having a conversation with the women and make the women be part of that decision basis. In terms of indications for immediate birth, if you like, in the preterm gestation, so women inability to control blood pressure despite using 3 or more classes of antihypertensive. So that's not adding nifedipine to a baby dose of labetalol. I need to get her in for delivery now. That's really escalating blood pressure medication properly. And then other features, as we've said, of significant end organ disease would be reasons for delivery before 34 weeks or before 37 weeks in a woman who's opted for expectant management. Steroids at preterm gestations, the timing of them is absolutely critical. So when you've made a diagnosis of preeclampsia at 27 weeks, giving steroids is not the first thing to do. How long might that woman stay pregnant? You don't know, do you? She might stay pregnant for a few days, but she might stay pregnant for many, many weeks. And giving steroids and keeping babies in utero for long periods of time is harmful. Steroids have their most impact when they're given 48 hours, 24 to 48 hours before birth. So where possible, always give you steroids after you've made a decision to deliver a baby, not before. And try and communicate that to your resident doctors. Try and have the conversation if your midwives and doctors are prescribing steroids within 10 minutes of someone walking through the door with a blood pressure of 170, 110. Just hold back, get the blood pressure under control, get the bloods back, get an assessment of the baby, and then think about whether you need steroids. All of that will take you an hour probably. So don't give steroids until you've made a decision that delivery is your only option, because steroids need to be given where possible, as close to birth as possible. Okay, last plug. I'm not going to go through severe preeclampsia, dead and very hungry. So I'm just going to point you to the QRH guides. Is anyone, are people aware of the quick reference guides on the Obstetric Anaesthetic Association website? I would encourage you to go and look for them. If you've not got them in your unit as flashcards on the labour ward, I would strongly recommend that you get them. There are about 20. They've been written by a very broad multidisciplinary team, and they're all obstetric emergencies, including 2.1, eclampsia, 2.2, pre-eclampsia. So they don't say anything that you don't already know, but they're very, very useful for the doses and instructions on, the order of events. There's one on hyponatremia, there's one on maternal collapse, there's one on, they're really, really cool. They've been written by Kirsty McLennan at St Mary's has led the team, but they've been written by a very multidisciplinary team. So do look to those for management of severe preeclampsia. This is one that is the eclampsia one. Okay, I'm going to stop there.